conflict on developmental disorders using genetic and epigenetics there. And my lab actually works on precise diagnosis. And first of all, do we have a precise diagnosis for any given condition? And if so, is there any precise medication for any given condition? And if not, then how to resolve it? And similarly, can we do disease forecasting there? So this is how the WHO also defines that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity there. So that these are the issues which we try to address in our lab with respect to various complex diseases. And the areas that we try to cover to address this particular aspect is by addressing the aspects of genetics, epigenetics, pharmacogenetics, and pharmacoepigenetics there, mostly with respect to various CNS disorders there, both developmental in nature and as well as neurodegenerative and neurovascular in nature also there. So coming back to autism, so now autism is definitely, we know that it's extremely complex. There is no two, it is believed that there is no two patient who is no two individual who is considered to have more or less the same symptomatic profile there. So therefore, this particular issue becomes makes autism much more complicated whenever it comes to genetics and epigenetics, or even symptomatic profiles and all that. I'll show you some of the examples of it, how complicated it becomes when you really try to go for various phenotypic or biochemical based diagnosis there. And autism is basically a spectrum of disorders where there are several other conditions which are associated with autism spectrum disorders there. And there is a strong genetic component, definitely, yes. And there is also a strong epigenetic component there. But the issue is that how do we literally address the issue of genetics and epigenetics? And when we try to look into the prevalence of this particular condition across the globe, and this is the data which presents from 2012 to 2021, which shows that the prevalence ranges from 1.09 to 436 per 10,000 individuals there. And this is mostly and South Asia has the maximum number of variations. South Asia, West Pacific is around 1.09 to 436. There's a tremendous amount of variation with respect to ASD prevalence there. So therefore, and there is a huge distinction between the male and female also, like there is a higher prevalence of male with 4.2:1 there. So therefore, one has to really address why males tend to have more autistic-like features and all that. So when we try to see that, yes, there is a huge amount of another issue in this particular prevalence data would be is that lack of awareness in many of the Indian states there. Like I can tell that yes, in Kerala there is a huge amount of awareness, but this may not be true with respect to other states in the country there. So therefore, determining the exact prevalence rate for autism in India it becomes a really challenging task. And so this brings to the topic again, like this is a paper there which came up from the University of Liverpool, which says psychiatric diagnostic is scientifically meaningless there, it says. And one of the reasons why it says it's meaningless is because there is no consensus approach for decision making and even for evaluation and all that. So the reason why I showed this particular slide was to justify that if we have to literally start working on autism, it's better that we try to develop a uniform protocol across the country for picking up the right individuals for autism diagnosis there. So that tomorrow no one really comes out with a similar observation that autism diagnosis is scientifically meaningless there. So we have to literally try to evolve a very, very precise strategy there. So some of the strategies, possibly I'll think of covering it in my presentation of what are the issues that we can think of resolving it while picking up the strategy, while developing a precise strategy there. And so when we try to pick up the issues of, so if I have to literally go with the genome-wide association studies, so this is what the Global Genome-wide Association studies on autism spectrum disorders that has been, which has shown that there are multiple genes that are implicated in the autism. This is definitely not the most exhaustive ones, but yes, it is still highlights a lot of genes that are implicated. But very interestingly, what you see it is that the drug that is being used to treat, there are only 2 FDA-approved drugs for treating autism, and both of them actually try to bind to the serotonin receptors there. And if you see that serotonin receptor lies in the chromosome number 13, and although there is a hit, but that hit is not about the serotonin transporter there. Sorry, not a serotonin receptor there. So one would really say that then why are we treating such individuals with serotonin receptor drugs there? So similarly, and when you literally see across the globe from various Jiva studies, you don't see a huge consensus across studies there. So why you don't see there is huge consensus even within the same ethnicity? You don't see the same observation being picked up. So you can see that, and this is from chromosome 1 to 20, and you can see the various ethnicities are listed here, and you don't see too much of a replication across ethnicities. And even within the ethnicity, you don't see that this particular replication really holds true in other study there. So this really brings down to an issue that why we don't see such replications and all that. And of course, autism is extremely complex in nature. As I said, that there is no 2 individuals who is likely to have a similar profile, similar symptomatic profile. Therefore, this particular issue becomes much more challenging, particularly with respect to autism there. And another issue with autism is about the higher number of de novo mutations there. That really comes into play there. And these de novo mutations are actually one of the most penetrating ones with respect to the given individual there. So I have possibly a data somewhere to show somewhere in the later one of my slides there. And now coming to the medication also, when you try to see the medication, as I said, that antipsychotic drugs are the most preferred mode of medication. And there are only 2 FDA-approved drugs. One is risperidone and aripiprazole. Both are actually binds to dopamine receptors and serotonin receptors then, and act as an antagonist for these serotonin and dopamines there. And another one is fluoxetine. Fluoxetine is also being used for multiple conditions. And of course, people also are using it metformin. And in fact, if you literally ask my clinician, who is also a neurologist, he largely treats his patients with mostly the vitamin therapies there. So that would really say that why vitamin, and he says that his vitamin therapy is actually really working phenomenally well there. And I'll show you one evidence why vitamin therapy possibly works very well in this set of patients and all. So even when I go with the evidences of risperidone and aripiprazole, you will see that it binds dopamine receptor and serotonin receptors very effectively. And so therefore, if I have to literally think of building up a strategy, I'll possibly think that yes, serotonin and dopamine and melatonin would be the central pathway, even noradrenaline would be the central pathway, which controls most of the symptoms of autism there. So if these are the molecules which actually controls most of the symptoms, then do we literally see consensus across study populations for the serotonin levels and dopamine levels there? To this particular aspect, I'll come on a later slide. That do we have a consensus on serotonin dopamine levels? And this particular slide shows that there is no consensus between the serotonin and dopamine levels across study populations. So this particular observation has been taken up from various literatures, which is available through online sources. And you can see that even the dopamine levels, which has been reported to be contrastingly different in the blood samples, and so is true with serotonin levels. So serotonin levels has been reported to be low in brain and CSF and high in blood samples there. And similarly for the melatonin also, it has been shown to be low. So how to resolve these conflicts, I'll possibly show you in one of the slides in coming, which is likely to come in due course there. So how do we literally resolve these conflicts between the study groups? So is it that should we literally consider low dopamine in my study population, or should I consider increased dopamine there? Because as a common man, as a common citizen, one would be really confused when people try to venture into the public domain for fishing out the articles and all that. And as a result, what we say is that whenever one has to literally work out on a disease as complex as autism, one has to first resolve the extent of genetic diversity that exists in the population, then also try to address the phenotypic diversity. Of course, if we try to address the genetic diversities, phenotypic diversity can be taken care to a large extent. And at the same time, can we address the epigenetic diversity there? And epigenetic diversity would be that can the environment, food, and other activities, can it really be controlled to a large extent and all that? So therefore, whenever we have to work out with such a complex disease, one has to really stratify these patient populations for genetic stratification, phenotypic stratification, and epigenetic stratifications. And to justify what is this genetic stratification, here you can see that this is one particular SNP site, which is also considered to be an autism risk loci, which is mostly associated with social interaction. And you can see that the A allele is actually associated with low social interaction, whereas the T allele is associated with increased social interaction there. And if you literally try to look into the role of A and T allele frequencies across the population, you will figure out that in the Africans, which is the YRI, MKK, and LWK, these are all African populations there. So you can see that the T allele is actually in a very high frequency, in contrast to the Chinese and Japanese, which is in the extreme end, which is CHT, CHB, and JPT. These are all Japanese populations, the Japanese and Chinese populations there. You can see that it is the A allele which is very, very high in these populations there. So ideally, if you ask me to interpret, I will presume that if this particular A allele is a risk allele for low social interaction, I will presume that the Chinese and Japanese actually have a low social interaction in compared to the African populations there. And if you literally try to look into the behavioral aspects, I would not really try to comment. But yes, possibly to a large extent, it will really reflect that in compared to Africans, possibly Chinese and Japanese actually have a low social interactions there. So just this is one particular SNP site. Now using a series of such SNP sites, I can really think because one particular SNP site will not be good enough to develop a stratification issues. So I have to literally use large number of markers to develop a stratification issues. And therefore, this you can see that the entire world population can be stratified into different continents. Like the green ones are actually so if I say that if there is a high prevalence of orange allele in all sets of markers, I can possibly give a pseudo color as an orange there. And whereas if all the blue alleles are actually more or less in all the 1,000 markers, if it actually segregates the same way, then I'll possibly give a blue color to the Chinese and Japanese and all that. So using this particular strategy, one can really think of developing a genetic structure of the population groups across the globe. And this is evident that all the Africans are actually clustered together, which is more or less green. All the Mongolites are actually clustered together, which is more or less orange in color. And all the Europeans are actually clustered more or less in a similar way, which is blue in color. And the Asians actually, mostly the South Asians and Middle East is where you tend to see there's a huge admixture between the various population groups there, which is evident from the various color reflections that you tend to see in this particular structure plot there. And when I try to amplify this particular structure plot in the South Asian populations, that's where the Indian population resides, you can further see that, yes, when I zoom this particular region where the South Asian resides, I can actually really see the finer distinctions between the Indian populations, that Indian populations are actually also made up of 5 different gene pools. So on the extreme end, you can see that it is the Indo-Europeans, which is blue in color. This is the Dravidian, which is red in color, and the Austroasiatic, mostly the Central Indian population, which is actually magenta in color, and Tibeto-Burman, which is mostly the East Asians or the Northeast Asians, which is mostly Northeast Indians, which is mostly reflected in blue in color, and this is the Ongis and Jarvas of Andamans, which is actually African origin there, which is actually green in color there. So Indian population also can be stratified into 5 different gene pools. And when I further amplify this Dravidian population, that is where I actually take out the Kerala population. So you can really see that when I zoom this particular Dravidian population in, you can further see that there is a distinctness between the tribal populations and the non-tribal populations there. So non-tribal populations are mostly green in color, and the tribal populations are mostly red in color there. So therefore, this particular issue really says that even in the Kerala population, we have 2 distinct gene pools. And India, yes, India has a large number of distinct gene pools there. When we keep on zooming between the Austroasiatic, Tibeto-Burman, we will possibly get more and more different colors, color coding patterns coming in, because there is a good amount of genetic distinction between the population groups there. So therefore, this method of stratification is very, very important. And similarly, when we say that genetic stratification we can really resolve, similarly we have to literally think of resolving that the phenotypic stratifications. Can we literally do a phenotypic stratification of the population groups and all? So here, yes, one of the way of phenotypic stratification is that can I see the males and females are different and all. Here it is visible that yes, males have actually higher level of serotonin production, which is 52% higher than in the women there. So therefore, the serotonin production is possibly much higher in the males. So that might possibly indicate a different spectrum of symptoms in the males in compared to the females there. And this is another fMRI picture where they have demonstrated that when a specific task was fMRI picture, when a specific task was given to Chinese and American, so they can actually excite different brain centers, and let us not worry about who resolved the task faster. But here the centers that you tend to see is in Chinese brain, and the American brains is distinctly different. And same is true when the population grew, when the populations are stratified based on the religious faith. The way they resolve the particular task is also quite different there. So this is a very good demonstration of how a particular how an fMRI task can resolve the brain functionalities in depending on the religious and ethnic backgrounds and all that. And is it really true that we tend to see a different in symptom profile? So when I try to look into my patient groups with respect to schizophrenia, I see that yes, certain symptoms are distinctly different between the schizophrenia patients from Chennai and the Kerala there. So the orange one is the patient group, schizophrenia patient group from Kerala, and the blue ones is actually the schizophrenia patient group from the Chennai patient population there. So more or less suspiciousness, hostility, blunted effect, emotional withdrawal, hallucination is more or less similar there. But if I have to literally interpret uncooperativeness, unusual thought content, I will presume that unusual thought content is way high in Kerala patient population in compared to Chennai patient population. So I cannot really say that this is basically justification bias from the evaluator's point of view there. So this clearly justifies that phenotypic distinctions has to be stratified based on the populations and all that. So we have done a similar study with respect to with the Bengalis in Bengal and Bengalis who are actually migrated to Kerala. The way they resolve the task is quite distinct when we try to evaluate their executive functions, and we found that yes, the method and the way they resolve the executive tasks is quite different with respect to the Bengalis who are actually present in Kerala and the Bengalis who are actually from Bengal there. So that data I'm not presenting it here. So therefore, based on these strategies, you will possibly start working it out about a hypothesis, and therefore you will start working it out on whether the neurological hypothesis is one, and whether the neurological hypothesis can be influenced because of immune dysfunctions, or whether it can be influenced because of GI dysfunctions, and whether they are all interrelated to each other or not. So therefore, one will start thinking of developing an hypothesis. And so what we did is we wanted to understand the hypothesis to a better extent by taking the genome-wide risk loci for autism, and then we did a selection analysis there for positive selections of all autism risk loci that has been reported in the GWAS data. And we found that some of this risk loci, which is evident here in the green, these are all recent in origin there. So these autism risk loci are all recent in origin, which possibly arrived, these mutations in these genes arrived somewhere around 2000 to 2500 years back. So therefore, this particular block, we named it as a de novo block, because this has actually evolved just in the modern humans. This was not present in the ancestral humans, ancestral species of Homo sapiens, or even in early modern humans there. This particular variants were not seen in the Denisovans also there. So therefore, this particular block, we named it as a de novo block. And interestingly, this particular block, the time it started also implicates that was the time when the human civilizational culture started there. So therefore, one would really say that yes, civilizational culture possibly gave rise to this particular block there. And what is the function of these genes? Most of these genes are actually implicated in the higher order brain functions there. So therefore, I would presume that this particular de novo block is mostly associated with Savant syndrome, whereas these particular blocks will be possibly more associated with because these are the ones which results in gain in brain function genes, and these are the which is basically loss in brain function function genes there. So this was through a functional selection analysis, and then we and this particular slide further justifies that when I group a set all autism spectrum disorders, this is again a recent data which indicated that this is not about autism spectrum disorders but developmental delay disorders. You can see that there's hardly any overlap between the various developmental between the various ASD risk loci across different study populations there. So you can see that this is a unique set of variants. So there are a large number of unique set of variants that you can see, and which has not been reported there. So many of these red ones, which are actually all unique variants, which has not been reported earlier there, which indicates that it's possible that in our study population, in Indian study population, we possibly might find out much more number of novel variants there. And it's possible that we might also figure out some newer set of genes there, which might not have been reported in earlier studies there. And when you try to see that, when you try to understand the spectrum of mutations and divide them into de novo variations, de novo mutations, rare inherited variations, and the common variations, you tend to see that yes, de novo variations actually has a higher effect size in compared to the common variants there. So common variants are present. These are all autism risk variants. So de novo variants actually have a much higher risk variant, has higher effect size there. And where are these de novo variants? And when I try to further stratify the autism spectrum disorders into an intellectual disability in epilepsies, you can see that the de novo mutations are more predominantly present in the intellectual disabilities and epilepsy groups, and this is developmental epilepsies groups. And so these are the various types of mutations that is shown here: frame shift, missense, stop gained, synonymous, non-coding exons, and splice site variants, 3' UTRs, and 5' UTRs, and introns there. So in fact, there are a large number of intronic variants, de novo intronic variants, which are actually seen in autism spectrum disorders there. in compared to intellectual disability and developmental epilepsies. And this is again a chromosomal widespread of various de novo mutations for both intellectual disabilities and autism spectrum disorders. I'm not going too deep into this particular slide. Only thing is, you can see that wherever there is an indication of means that there are more than one de novo variants that has been identified in that particular region there. So now coming back to this particular slide again, is that how do we resolve this conflict and the biochemical profiling or monoamine levels in autism there? To resolve this, we have done a small study where we have tried to see that whether we try to look into the dopaminergic biosynthetic pathways and degradation pathways, and so is for the serotonin synthetic pathway and the serotonin degradation pathway there. So what we see is that what it means is that if your tyrosine level intake is less, even if it's normal, and you are not able to convert tyrosine into L-DOPA because you don't have a sufficient amount of enzyme activity there. So therefore, this particular mutation results in decreased tyrosine hydroxylase enzyme activity. Therefore, you are actually you have a reduced L-DOPA, and reduced L-DOPA will further result in reduced dopamine levels there. And on another side, you have monoamine oxidase A, which is responsible for degradation of dopamine, and the variant that has been found to be associated with monoamine oxidase A gene is actually associated with increased activity there. So which means that there is an decreased dopamine levels because of the lack of poor synthesis of because of the poor enzyme activity of tyrosine hydroxylase, and you have an increased degradation there. So therefore, whatever level of dopamine is being produced is actually further being is undergoing degradation. So therefore, I will presume that there's a decreased level of dopamine is more applicable in my patient scenario in compared to the other in compared to the increased dopamine levels there. So therefore, if I go back to this particular slide, I will say that in my study population, I would possibly presume that there will be decreased dopamine levels is more applicable in patient samples there. Now, if this doesn't turn out to be true, then I have to literally start thinking of worrying whether if there is no one-to-one correlation, I would presume that it could be because of epigenetic mechanisms there. So is it that the epigenetic mechanisms is really playing a role in altered dopamine levels or altered serotonin levels there? So here also, of course, we don't see much in the serotonin pathway. We don't see much, but of course, in the serotonin pathway also monoamine oxidase is involved, which is which is associated in increased activity. So I'll presume that even if you are producing normal level of serotonin, which is actually undergoing good amount of serotonin degradation there. So, and very interestingly, many of these neurotransmitters also have a circadian rhythm there. So therefore, from morning till evening, you actually have a different levels of neurotransmitters there. And interestingly, we find there are some of the circadian rhythm genes like NPAS, period 1, period 3. They are also genetically associated with autism there, which indicate that this so this might also influence their rhythmicity there. So therefore, depending on the day of synthesis, so if it is actually impacting its circadian rhythm, one would really say that it will further impact the dopamine synthesis also there. So the data, I'm not presenting it here because of because of the sensitivity of the data, because it is still not published there. But if it's a physical meeting, I can possibly present all this data also here. And interestingly, further, if you literally see that there are some of the DNMT variants which is also found to be associated. This DNMT variant is actually published, so therefore I can show the data in I think subsequent slides then. And this is just to justify that yes, there are a large number of metabolites which actually have a circadian rhythm there. So therefore, this circadian rhythm, and which we have also reported that yes, one of this metabolite like homocysteine, where we have controlled homocysteine is being metabolized by MTHFR gene, we control for the the genotype for MTHFR genes in a couple of individuals, and we had an altered H-clog genotype individuals, and we found that these H-clog genotype individuals actually have an increased homocysteine levels there in the early morning there. So therefore, homocysteine also has a circadian rhythm, and so is true for many of the neurotransmitters and other metabolites also there throughout the body. So therefore, and these metabolites will also be influenced because of many dietary factors, many environmental factors. And so it's true that autism is also influenced by a large number of environmental factors. Both it has the nutritional domain, it has the chemical dimensions, it has the social dimensions, and it also has the physiological dimensions there. We are working on the saccharine stress on autism, on pregnant mothers of autistic probands. So we have the data, but we are not published. So therefore, I am not showing it here. And so one of the issue of environmental factors is, yes, the children who are actually born in the winter months are more prone to develop autism there. But the question arises is that, is it that all children who are born in the winter months are prone to develop autism? And if not, then who decides the threshold there of the environmental impact there? So therefore, I'll justify that, yes, there are certain genes which actually decide the threshold of environmental impact there. And it is not that every child who is born in the winter months is prone to develop autism there. And as a result, whenever you try to think of working it out on the environmental factors and all, the best molecular factors that you will think of working it out is on the histone modifications, microRNAs, and DNA methylations there. These are the molecules which are actually, I will say that these are the mature markers of histone of epigenetic parameters. And when I literally see that and how to resolve this particular DNA methylation, microRNAs, and histone modifications there. So I'll switch gear here because we have a huge amount of data on schizophrenia with respect to histone modifications, DNA methylations, and microRNAs. Therefore, I'll take an example taken examples from schizophrenia here. So these are the data that has been presented with respect to schizophrenia for various global methylation alterations, hypermethylation of various genes, and of course, expression patterns for various GABAergic genes, and of course, DNMTs and all. But the issue is that when we started working on epigenetics of schizophrenia, we actually questioned many of these evidences, saying that these observations cannot be the real observations of pathogenesis there. The reason for questioning this particular observation was because most of the samples, most of the studies have been performed in the postmortem samples. And as a result, I will presume that those postmortem samples must have been influenced because of medication issues itself there. So therefore, is it that the medication issues is really impacting the methylation parameters or microRNA parameters and all that? And then, of course, we have published many of these evidences. So this particular article we published by questioning these evidences as a perspective article in epigenomics, and then we provided two series of evidences where the drug impacted the methylation parameters and all. I'm not showing it here because it's mostly on schizophrenia. So therefore, we have shown that it is. If anyone wants to go through these articles, one will find it out that yes, many of these observations actually indicate that the antipsychotic drugs do play a tremendous role in alterations of methylation, microRNAs, and so on and so forth there, which is shown here. And I'll give you some examples of it, but not in detail that. And another issue is that we also took one of the papers from here, and we said that because that particular study where they have done on the methylation parameters for pathogenesis on American populations, where American populations were actually from both white Americans and the Black African Americans there. So what we did is we actually segregated this particular data into African and American, white Americans and Black Americans, and we wanted to see whether is it that there is a distinction between the white Americans and African Americans with respect to methylation parameters and all that. I'll come to that later. So when I question that particular methylation observation in schizophrenia, so is true for one can think of questioning the methylation parameters in autistic cerebral cortex region itself, because these postmortem brain regions you only get through postmortem samples, and these postmortem samples possibly might be influenced because of multiple factors there, and these multiple factors can actually really influence the methylation parameters there, and medication would also be one of those factors there. And since the medication here also it is antipsychotic drugs, so therefore I presume that yes, antipsychotic drugs do influence the methylation parameters there. And so one would really question, do antipsychotic drugs interfere with methylation parameters? Yes, they do influence the methylation parameters. And even it also influences the folate cycle, the methionine cycle also there. And largely what happens is whenever people try to do studies is mostly with the case and controls. So when we were also working it out, we also found that yes, there was an increased, there was a hypermethylation state when I segregate the patient versus control. I see that hypermethylation state is actually more applicable in the patient population. But when I segregate this particular patient population into responders and non-responders, now you see that the hypermethylation state is more associated with good response in compared to the non-responders individuals there. So therefore, one has to really think of have to understand the underlying factors between the patient groups there. Are they literally constituting the responders and non-responders also? So this so these are the issues which comes with respect to with schizophrenia, but so it will be true for autism also there. And then we did an 850K methylomerase, which is the largest methylomerase that has been performed on schizophrenia in Indian populations. And then we try to segregate between the drug naive and the controls, the drug naive and responders, and drug naive and non-responders. Yes, we see that there are several methylation marks which are actually unique to drug non-responders. There are certain marks which are unique to responders, and these are certain marks which are unique to drug naive. These are unique to non-responders. These are unique to responders. And when I try to compare our observation for differential methylation sites, methylation probes, and with respect to published literature, what we see is that all this, don't have to worry about reading all this. All this methylation probes, which actually have been implicated with respect to schizophrenia pathogenesis, now actually they are also being now in our data, they are all actually a mark of drug response there. So therefore, one has to really start wondering the DNA methylation markers, the probes, which has been implicated for pathogenesis. One has to start re-looking into the particular data, because they may not be the real marks for pathogenesis there. So this is not only true for methylations, and these methylations can happen, of course, anytime in your life cycle, and so is true for the microRNA. That is where I literally said that whenever we have to literally start thinking of methylation or epigenetic marks, one has to start working out very carefully these observations there. So as I said that yes, there are a large number of, so when we started working on microRNA profiling on schizophrenia, these were the observations that were available at that point of time. And you can see that there are a large number of microRNA that has been all reported across various different studies, which has been reported to be downregulated, upregulated, and so on and so forth, in various studies. And when we try to do an in silico analysis of how many of these do this microRNA also get altered because of the antipsychotic drugs, and we did find that yes, antipsychotic drugs do impact the microRNA profiles there. So large number of microRNAs actually are impacted because of the antipsychotic drugs. And therefore, since this was an in silico study, we wanted to perform an whole genome microRNA study. And then we try to find out that do these microRNAs really are impacted by the methylations? Sorry, by the antipsychotic drugs. And yes, we actually did for haloperidol, clozapine, and a combination of haloperidol and clozapine. We found that yes, there are several. All the yellow ones that you see here are actually the direction of the expression is the same there. So you can see that miR29B is downregulated. That has been reported to be downregulated in schizophrenia. Whereas in antipsychotic drugs, we also see that there is a downregulation there. miR181B has been found to be upregulated in schizophrenia, but we also find that this same microRNA has been found to be upregulated by antipsychotic drugs there. So therefore, it is the same set of microRNAs which actually have the same direction of expression there. And this literally poses concerns for all microRNAs, and this particular work we have published in Frontiers of Molecular Neurosciences recently. That antipsychotic drugs and all these drugs should be first assessed whether are we literally dissecting out the real markers for pathogenesis, or are we looking for markers which are influenced because of various other or influencing factors, like in this case antipsychotic drugs there. And is it true that the microRNAs has been reported to be altered with respect to drugs in autism? Yes, in fact, this is a very interesting paper, a very exhaustive paper, where they have shown that alteration in microRNA in fetal alcohol syndrome, alcohol spectrum disorders, anesthetic-induced developmental neurotoxicity, and fetal exposure to nicotine and virus infections, they do impact the microRNAs there. So therefore, there are a large number of drugs and various habits, and even viral infections can actually influence the microRNAs there. So therefore, whenever one has to really think of looking the microRNA expressions, one has to really think of controlling those factors there. And then what I was telling earlier about African Americans and about the white Americans and the Black Americans. So this is the data where we segregated between the white and the Black Americans, and we found that there are several such marks which are actually distinctly different between any dot that you see beyond this particular line is found to be very significant there. So in the controlled populations of Black and white Americans there. So we can see that there are plenty of marks which actually differ between the white and Black Americans there. This is in the controlled population, and so is true for the schizophrenia patient group for the same data sets there. And this is and in this another side, you can see that the direction of the methylation probe is also quite different, distinctly different there. Here in the white Americans, it has been reported to be hypermethylated, whereas in the African Americans, it has been reported to be hypomethylated there. So there are a series of such discrepancies between the methylation sites in the American population itself there, when we stratify them based on the ethnicities and all that. So therefore, these ethnic backgrounds has to be very, very carefully taken into consideration. And one would really ask that, is it that the methylation sites are influenced because of the ethnic parameters? Yes, we can say that yes, methylation sites are influenced because of the ethnic parameters then. And therefore, what we did is we tried to see the genetic variants in the methionine cycle genes, demethylation genes, and the methyl transferases there. So these are the genes which are actually endogenously control the methylations, and these needs the cofactors to control the methylation parameters there. And when we look into the genetic variants of these genes, we found that yes, there are certain variants in the DNMT genes, DNMT1 and DNMT3. They all are genetically associated with autism, and the role of this particular variants are actually associated with increased expression there. So therefore, increased expression of these variants might indicate that there is an increased methylation state in schizophrenia, sorry, in autism. And when we try to look into this, is since I'm presenting the data, since this data is already published. And so is true when I stratify between the males and the females. There are a large number of genetic variants which are strongly associated with males, which in contrast to the females there. So therefore, one would really say this might possibly explain the differences between the male and female prevalence in the population groups there. And what is its implications? So implications would be that these genetic variants will decide the threshold of the environmental impact there. So here, while this is in the schizophrenia, and so would be true for the autism also there. So therefore, if it's a winter month is actually responsible for autism, I would presume that the winter month might be possibly influencing the expression of these genes there. Because of this particular variants there. And now, if I try to extrapolate this particular expression patterns with respect to various tissues in the brain, I see that there's an increased expression in the cerebellum, cerebellar regions, and therefore, if the variant is actually associated, I would presume that there is likelihood of much more increased expression under a given stimulus there. So therefore, I can possibly think of extrapolating it that this observation, which has been reported by someone else, and not which shows that there is a decreased expression of these cerebellar regions, and this decreased expression of cerebellar regions possibly can possibly impact the expression of these regions in the brain there. Of course, this is an extrapolation. This has to be verified, but verification becomes very, very challenging because you cannot get fresh brain there. And therefore, I did write an article, an editorial in this particular aspect, that the genetics of epigenome might hold clue for determining threshold of environmental impact. And yes, there are several such not only DNMTs, but several such methylation genes, which are responsible for controlling the methylations, have been implicated in the autism spectrum disorders there, which has been listed here there. So now the ethnicity has been covered, environmental factors have been covered, drug has also been largely covered, but I'll possibly divert the attention towards a slightly different aspect of drugs, because large number of drugs have not been tested for its teratogenic potential there. So therefore, I would start questioning is that why do we tend to have large number of de novo mutations there? Is it a large number of de novo mutations is basically because of the higher load of various metabolites, or is it because of the higher loads of various drugs? So that is one of the issue which one has to really start wondering about it. And so you can see that 91% of drugs have not been tested for teratogenic potential there. And if you literally see that, what are the drugs? What are the impact of these drugs? We all know that, yes, with respect to anti-epileptic drugs, it can result in large number of malformations, including cleft lip, various types of heart wall defects, then spina bifida. So many of these defects have been reported with respect to anti-epileptic drugs there. And it is not only, so this is a very mature field with respect to anti-epileptic drugs, but there are still large number of drugs which are still coming into public domain, like use of paracetamol, aspirin in pregnancy can develop the risk of cerebral palsy in the child. And this is not with 1 or 2 or 100 samples, but with respect to 185,000 mother and child pairs there. And so is true for diclofenac. Diclofenac use and the cardiovascular risk. It has been reported that diclofenac poses cardiovascular health risk compared to the non-use paracetamol use and for other traditional non-steroidal NSAIDs there. So diclofenac has also been reported to have a serious risks, and so is true for a large number of NSAIDs that you can see here. So NSAIDs can result in large number of cardiac arrest issues. So, And these drugs, actually, one has to really start thinking about it, whether the drugs and are they literally influencing the development of autism spectrum disorders there. And if you literally ask me, is it really true? Yes, there are certain drugs like valproic acid has been reported to enhance because herbs and cytokines are known to be associated with autistic children, and drugs like valproic acid actually can induce the expression of several herbs and cytokines there. Whereas antiviral like efavirenz can actually inhibit them there. So therefore, one can really say that antivirals possibly can actually can be very useful in treating autism there. But may not be in every individual, but yes, one has to really look into case-by-case issues and all that. And there are, of course, I have already shown that non-coding RNAs can actually be are reported to be influenced because of large number of various anesthetic drugs, nicotine, and viral infections and all that. So this comes to an issue that then how do we really understand how does the antipsychotic really works there? And this takes to our observation that we found that the pro-inflammatory cytokine are largely genetically associated with schizophrenia there, and it is mostly the high producer alleles are actually mostly associated with schizophrenia, which indicates that schizophrenia is more or less a pro-inflammatory condition there. And so is true for autism also. Autism is also considered to be a pro-inflammatory condition there. And therefore, one would really start thinking that it is the presence of quinolinic acid which can actually enhance the NMD-induced toxicity directly or through increased glutamate levels, and therefore it can really result in increased neurotoxicity there. And one would really start questioning: is it really true? And so this is an evidence that we got again that haloperidol and clozapine are highly immunosuppressive in nature, and therefore one would really start thinking that the antipsychotic effect that you tend to see in schizophrenia possibly might be because of the use of haloperidol and clozapine as an immunosuppressive effect, and may not be possibly directly through the dopaminergic serotonergic receptor sites there. Of course, there's a thought. One can really start discussing this particular aspect in greater detail. So with this, of course, this I'll skip. Thank you very much. This is my institute. You all are welcome to visit our institute anytime. Are you all there?
Yes. Thanks for a wonderful talk. Can you stop sharing your screen, Moinak?
Yeah, sure.
Yeah. Thank you. It was really interesting, and it still continues to be an enigma. I request Krishanu to say something because he has another meeting to leave to, and then Vinod and Biju. Thank you, Dr. Biju, for joining. Thank you so much.
Yeah, thanks, Moinak. I think it was really a very extensive tour of the whole subject, ranging from autism to schizophrenia, and such a vast study of both drugs and the genetic variations that we have observed. So overall, I'm really, I learned a lot today, actually, honestly speaking. And with my basic training in genetics, it seems that it is an arduous task.
Yeah.
Really link the phenotype to the genotype with so much variations in the background. So one thing it is clear to me is that this kind of manifestations, what we call autism or other manifestations like bipolar or schizophrenia, is not really a simple, protein phenotype kind of association. It's not that one protein malfunctioning can give rise one type of defect. So each of these is a broader symptom which manifests because of a large range of disruptions. So what is interesting is that the number of missense mutations that you have observed associating with schizophrenia and bipolar disorder compared to autism. That's something is very striking. So have you thought, and also in case of autism, it seems that the intronic mutations are more prevalent. So have any thought about,
Yeah,
why?
actually, now we have actually tried to understand, because many of these intronic mutations are also the regulatory regions there. That's where the regulatory regions reside there. So we are actually trying to look into the 3D genome, which is where the TAT domains resides. So we are trying to look into the TAT domains of the autism patients, and also for the schizophrenia patients. How do these intronic regions actually regulate the function of other upstream genes and downstream genes there?
Yeah, that's my 2 bits actually.
Right.
But it's really impressive. Thank you, Mainak.
Right. Thank you very much, Krishanu.
Thank you. Thank you, Krishanu. Vinod?
Thanks, Mainak. Thanks, Mainak, for the fantastic talk. Sorry for my voice, but yeah. So I have just a quick question, probably, that you sort of described in very great detail the different genetic, epigenetic, environmental, pharmacogenetic, and other risks for autism spectrum disorders. In an era where, for example, whole genome sequencing would become the mainstay, and with one sequencing, you could also, for example, decipher the genome, the epigenome, the structural variants, all put together. How do you think that is going to really change the understanding of autism spectrum disorders, and in a clinical setting, how is it going to really impact the diagnosis? It's probably an open question that I would want to put across.
No, so you mean to say that how this genetic and epigenetic screening is going to help?
That's right.
Yeah. So the first and foremost thing is that, as I demonstrated with respect to dopaminergic pathway, first and foremost thing is that we have to literally demonstrate whether the genetic pathways are really, there is a direct relationship or not. The moment there is a contradiction of the genetic pathways, then one has to really think of looking into the epigenetic pathways there. So therefore, the first and foremost thing is that, irrespective of whatever studies thing, so one has to really start thinking of genetic pathways first, and then try to address the issue of epigenetic pathways there. And most often it will go hand in hand, because in the complex disease like autism, you presume that there will be a lot of epigenetic mechanisms also playing a role there. So I would start thinking, because one of the issue of autism is that because microRNAs and all are very, very unstable there. So therefore, whenever it comes to epigenetics, the first and foremost thing is that the DNA is available. So one can even think of looking into the same DNA for both the genetics and methylation parameters there. And once you don't see any correlation with the genetics and methylation parameters, then the next step would be to look into the microRNAs and histone modifications and all that. Of course, histone modification methylations can also be covered in the same study there.
Right. My other quick question was also prompted by your slide on the stratification of the population and the admixture of the population.
Right.
Which is very, very contrasting with the rest of the world, which is quite homogeneous, where large-scale genome-wide association studies for tens of thousands, if not millions of samples are possible. Now, with a stratified population and with a large admixture in the population, how do you think, as a community, should we focus more on looking at unbiased genome-wide associations, or should we look at more of familial reference and looking at Mendelian kind of inheritance? What would be your thoughts on that?
Yeah, but familial nature of autism, it's very unlikely that you'll get it there. Right.
Yeah, and very rare.
Very rare. So therefore, one has to really start relying more on the population-based screening itself there. And it would always be good to look into the trio-based screening. For a simple reason is because autism is actually, since you tend to see large number of de novo mutations, one has to really start worrying about what is the role of these de novo mutations there. In fact, we get large number of de novo mutations than the real pathogenic mutations there. in autism there. So that is really because one has to start worrying why we tend to see large number of de novo mutations there. And probably one of the reasons that we tend to see large number of de novo mutation is because of the extensive amount of metabolites which is actually playing a role there. So is it that the metabolites are playing a role? And even we have actually done a very interesting study on the role of circadian stress there. So you'll be surprised to see that we were actually trying to look into the circadian stress with respect to Bengalis who have migrated and Bengalis who are from Bengal itself there. And their executive functions that we have tried to understand it. And you tend to see that I have not presented this particular slide here, but it is very interesting that certain parameters of executive functions really differ in the migrant Bengalis there, in compared to the resident Bengalis there.
Yeah, thank you. Thank you very much. Fantastic talk.
Right. Thank you very much.
Thank you. Dr. Biju, autism is getting more and more complex. Are we unraveling it or we are making it more complex? I don't understand that actually.
It certainly is getting more complex. And thanks very much, Dr. Banerjee, for that fantastic talk. And as Professor Shefali has said, it just shows like how heterogeneous the condition is with not just the genetics, the epigenetics and environment. I'm sorry, I was a bit late in joining the talk, and when I joined, the first slide I saw, second or third slide I saw was the one which you showed on the scientific diagnosis. Scientific diagnosis is meaningless, yeah. Which is quite interesting because you know, there are lots of conditions which were associated with or related to autism spectrum, like for example, Rett syndrome, Fragile X, etc. And in the DSM-5, for example, Rett syndrome is not included in it's been removed as one of the autism-related conditions, and that's because the gene was diagnosed for Rett syndrome. Previously, when Rett was included, the gene had not been, the MECP2 gene had not been recognized. So, and then subsequently, when the MECP2 gene was identified, then Rett was removed. But also in Rett, as you know, the autism features only exist in a specific window. Subsequently, during the regression period, and subsequently they tend to become more social. So my one question was like, now that like we are finding more genetic basis for autism, and as you showed in your slide, GRIN2B, FOXP1, FOXP2, FOXG1, I don't know whether whether we should still be diagnosing autism based on behavior, or we should be going for more like syndromic diagnosis, like with having a genetic basis for each condition. That was one thought which I had left on seeing that slide. But my main question to you was, which was quite intriguing, like your description of the epigenetic factors, which, so as a practicing clinician, what the neurologists want is early intervention, because we all know that early intervention is going to make the difference. So my question to you was, how, in your opinion, how is the epigenetics going to help us make that early diagnosis? Or like, I can think of like a couple of scenarios where, like, for example, if you have a unique methylation pattern or an epigenetic marker, which shows that like behavior intervention is going to work better in this particular group, then we would then more target behavioral interventions. Or if there's a particular drug which will modify the epigenetic marker, then we can use that drug. Or maybe find unique methylation patterns even prenatally. So what is the current state of play in epigenetics in regarding prenatal diagnosis or towards precision medicine in autism?
Yeah, so in fact, what happens is whenever it comes to clinical early intervention, so possibly what we try to look into is that the medication issues there. So and therefore the medication issues possibly may not be the real way to address, And because there's most of the medications are target-based approach there. And what we are trying to shift the gear is basically one should not really focus on the target-based approach, but one should really think of looking at the modulator-based approach. And what are the modulators? The modulators are basically the cytokines there. Like autism. Autism is basically a pro-inflammatory condition there. So can we control the pro-inflammatory condition? Yes, we can control the pro-inflammatory condition there. So stress is one of the major factors for pro-inflammatory condition. And if you carry the genetic risk for pro-inflammatory condition, you're definitely bound to develop pro-inflammatory condition there. So therefore, we can really, if I get to know that you have a higher threshold of, you have a lower threshold of pro-inflammatory condition, you should be minimizing the stress to a large extent there. And we are actually going to, we have just finished a paper, and I think it's already communicated, where we have demonstrated how yoga is actually playing a role in controlling the symptoms of schizophrenia there. This is with NIMHANS, we are actually going to publish it there. So where they have been controlling and this particular yoga has been found to be almost better or almost equal to antipsychotic drug use there.
So that's interesting. So in terms of the interaction between the genetics, the epigenetics, and the environment,
right?
In your opinion, do you think it would be more cost effective to focus on the environment, or how much is the effect of environment on the epigenetics? Perhaps because environment is relatively easy to modify, isn't it? In fact, I think Dr. Kavita had a question as well on what is the role of mobile radiation, etc. So is it more cost effective to focus on the environment?
Yes, it is much more easier to focus on the environment, because what will the environment take care is the environment will take care of your of immunological pathways. Environment will take care of your genetics of methylation, like DNMTs, folate pathway genes. Because in fact, I was told in one of my neurologists who is actually treating autism, so he's getting a lot of cases from.
No, you did mention that, and I wondered perhaps there is a basis for this, giving this vitamin cocktail.
I think you might be knowing also because he's a very well-established neurologist, Dr. Suresh there.
Yes, I know. So you did mention earlier. So yeah, perhaps there is a basis for this.
Right, and we also find, because these particular one common metabolism pathway are actually implicated not only in schizophrenia but also in autism. We have published in autism, published in schizophrenia, published in Alzheimer's disease, and also published in stroke. So this one common metabolism pathway and the DNMTs are actually implicated in large number of diseases there, and so is true for the immunological pathway genes there.
And interestingly, some of my autism patients, at least like 3 of them, were subsequently found to have cerebral folate deficiency, and which is now recognized, and they were already on folate supplementation for other reasons, and it seemed to work. So interesting.
That's interesting. Yeah, that's very good.
Thanks, Dr. Banerjee. Thanks, fantastic job. Thank you.
Because these insights are very useful for us.
Dr. Maina, Kavita has written, Dr. Kavita Srivastav from Pune has written, what is the epigenetic role of electromagnetic radiation, pesticide, screen time? And she's talking about EMF from the mobile towers. And I'm adding to this question, how about third trimester exposure to air pollution? And second question would be your take on paternal stress, because we have recently done a study and we found that the sperm epigenome, there are methylation defects in fathers of children with autism spectrum disorder. It's not published as yet. So I do not know. I think it's getting more complicated, autism, rather than unraveling the thing. And, because there's so many things we don't know. Actually, one more question is, there may be so many defects, genetic, epigenetics, but which are the pathogenic ones is what you want to know. Right. Because see, if you do my testing, I will have many things abnormal, but I'm fine. Right. So, what is functionally, what is pathogenic, we don't know. So, I don't know, how do you guide? So Dr. Kavita's question, and I added some on mine.
Yeah, so like EMF and this mobile, yes, it might possibly have a huge impact on the methylation. which is, but demonstrating that particular evidence is slightly difficult. We can only do it in the under the cell culture condition. I think someone has already done it, but not the methylation aspects there. So
No, but you know what? We did read, right? You know, there was a brainstorming for one DST project. Everything was done for following up antenatally pregnant mothers and following up the neurodevelopmental outcome till 2 years, plus look for autism. Everything fine, but it was shoved because we could not find any way to quantify the amount of radiation with the EMF. So, I mean, because of want of that, the whole thing was shelved. I mean, this brainstorming was useless. So I don't know what is the other way to do it actually.
That is the most challenging task of quantifying these radiations there. So I don't know how to do it, but that's really challenging of quantifying what is the amount of radiation that a person is exposed to. So
air pollution. Air
pollution, yes, definitely. One quantification of air pollution. Yes, one can really think of looking into because we have to break down the air pollution with respect to pesticides and all that. So one can really look into the pesticide residues and all that.
No, pesticide, I'm bothered on the food actually. Our food, it may be news to be Dr. Biju, but our all food is contaminated with pesticides.
Right.
Dr. Vinod will add on to that. Dr. Vinod, what is all this is doing? Food contaminated with pesticides. We are having so much malignancy. I mean, I don't know whether that is causing it, but anyway, autism, they have shown association. And with the third trimester, some particular parts per million of the air pollutants, and not the pesticides, the general air pollution, we keep having in northern India. I think you are, I mean, much healthier.
You will be surprised to know that there is a study that has been conducted in Canada some time back, where they were actually trying to look into the role of antidepressants in the fishes there. And these fishes are being routinely taken for human consumptions. And therefore, there is a huge amount of intake of antidepressants for human consumptions there.
That's true.
So, I think this was published just last week or a month back. I think it was a news all over.
Lots of psychiatric medications in the water, but also in terms of the parental age is an established significant risk factor, isn't it? Yeah, parental age, higher the age, So
right. Yeah, it's not.
I tell very clear, openly and clearly that it is paternal as well as maternal age, so that is one condition I can.
It is parental age, but I think the studies have found the sperm methylation patterns in older males. I think,
yeah. That's what I mean is it's better from the social point of view. I'm saying in India.
See, parental age, particularly the father's age, is also a tremendous amount of raises a lot of concern. Because see, depending on because they keep on producing sperms, and therefore they are continuously millions of sperms, and as a result, what happens is they are more prone to be mutations there. So whenever a cell undergoes cycling, so therefore any small amount of changes can actually result in impairment of the sperm genome there, and that will really impact the offsprings also there. Yes.
Mahesh, you're mute.
Dr. Kavita has asked about the role of chemicals like PFAS from the non-stick cookware, which get irreversibly incorporated and give rise to epidemic mechanisms.
Can you upgrade her to panelist? Let her speak herself. Kavita, we just asking you to speak. Can you make her unmute her? Yeah, Dr. Kavita, okay. Like you to speak. Yeah. Can you speak now, Kavita?
One second.
You can unmute her. I actually feel, I don't know, I mean, how you will have to tell, Krishanu had to leave, but you and Vinod will have to tell how far are we, and you have reviewed so much, from actually getting definite therapeutic intervention possible targets, by all this stuff, because I personally feel that it's the epigenetic factors which we can actually hit out and which may be the game changer. I mean, So, I mean, this is a personal belief, I feel. So I don't know which ones are we going to target, and that will be important.
No, that's what I think what Dr. Biju was also saying. It is because of the folate pathway genes, which is actually acts as a modulator, or the DNMT genes, which actually are responsible for controlling methylations. And these can be addressed very, very easily by the diet and all that. So one can really think of using that particular issues as a modulator factors for early intervention there. So particularly in the during the stage of pregnancy, one should not be devoid of such dietary factors which actually really impact the methylation parameters, which impact the immunogenetic parameters there. So one should be really sufficient for the immuno for the drugs which impact the immunological basis. And similarly, one should really think of taking the diet which is actually impacts the methylation basis there. Like folic acid and vitamin B6, B9, B12, including vitamin E. All these things are very, very important there. Vitamin D is also equally important there. So early intervention, that would be I would suggest, yes, one can really think of focusing on those aspects.
Any issue on making her speak unmute? Then I can read out now. She's written even chemicals like PFAS leaking from non-stick cookware gets irreversibly incorporated and give rise to epigenetic mechanisms. It also causes a lot of.
That is all true, because increased amount of this PFAS and then the cookwares that we are using it, you'll be surprised to know that, the red meat and the processed meat, they're all listed as a class 1 carcinogen there.
Red meat, processed red meat?
No, just red meat and the processed ham and pork and all these things are considered to be class 1 carcinogen. You can check it out in the WHO site. They're all considered to be class 1 carcinogen there, just like smoking,
And also even in non-stick cookware, the polyfluoroalkanes, the PFAS, the industry standard says that you have to renew them like every few after this much amount of use. But in resource poor settings, often you buy a cookware and then even if there are scratches, you just continue to use it for like decades, and then it makes it even worse.
Right. And there's no one knows what is the use of this wooden cookwares there, but people actually use this metallic cookwares even in those non-stick cookwares there.
Exactly.
So that is even more dangerous there.
Yeah.
Because you're spoiling the PFAS there.
Exactly. Once you get a scratch, then you are breaking the seal, and then you are creating more. Yeah.
It's much more dangerous there.
Dr. Mahesh, you can read Dr. Bijoy's question. If there is
Sir,
some technical issues of making them speak.
Right.
You can do
One more question, sir. Do cultural practices and parenting practices affect the epigenetics and the prevalence of autism?
Cultural practices
And parenting practices.
Parenting, yes. But I'll say that I like the data that you tend to see from the Western literature. I can tell you from my experiences, couple of my students and their kids and all, when they were in US or in Japan and all, the kids were actually very aggressively being listed into the autism care things there. But when they came back to India, they're completely normal there. So therefore, there's an aggressiveness for actually enrolling them into this particular autism thing there. I presume to a large extent in Kerala also the same thing is happening there, because it has become a buzzword now that if you literally label an autism center, you'll possibly get a lot of money there. So that is where the problem comes, because there is an aggressiveness that's where the migration there. Migration definitely impacts your social well-being and all that. Like, for example, I can tell you my own son there, he had difficulty in speech. So he started speaking for in 6 months. But then what happened is he used to speak at home. He used to speak Bengali, whereas in the house owner's house, he used to pick up Malayalam there. So what happens is we teach him Mook, and whereas in Malayalam the Mook is completely different. Nak is completely different in Malayalam there. So then he stopped speaking altogether. He said, "What is this? These people are confusing me." And for almost 2.5 years, he did not speak. So then we had to put him into a play school where he can distinguish between the Malayalam and the English and Bengali is very clearly there. And after that, we have to literally ask him to stop speaking there because he speaks so much there.
No, that's a very valid point, because
Right.
part of the reason is like loads of children are being misdiagnosed, with
Right,
autism,
absolutely.
particularly the ones with intellectual disability, learning disability, specific language delays, or
Right.
even like normal language delays.
Right.
Multilingual environments, those children are like often misdiagnosed as autism, and it's very important to tease this out, the
Right,
difference between autism and then the intellectual disability. I don't think that's a major problem. That's why, and part of the reason is once you label somebody with autism, even
Right.
in the UK, for example, in order to get entrance into special schools, you need that label, and sometimes it is just for that label's sake. These children are often diagnosed with autism.
Right. So that is true, because these are very complicated issues. So definitely parental care is really like, if we had not understood it very precisely, we would have possibly registered him as in the autism clinic itself there because of a language disability there. But he's completely normal there.
Now, Dr. Mainak, 1 second. Dr.
Right.
Bijoy straightforward asked that, is there some role in parenting?
Right.
If the
absolutely.
parenting is not okay, I understand it was in the 1950s and 60s that refrigerator mom condition was there. I mean, that was okay. That's wrong thing, which was gone. What I mean is, from epigenetics, he's asking whether somebody is having a predisposition and his environment at home has can tilt him either side. I mean, is there a modifiable thing or not? I think that's
Yes.
what Dr. Bijoy wants to know.
Yes, parental, actually, that's what I'm saying, that if I had not understood my child, and if he had been put up into autism center, he would definitely gone towards towards developing autism itself there.
So also stress and anxiety, like you said,
Right.
Philip, with the yoga, how yoga releases
Right,
stress.
right.
I remember Brajesh used to say in one of his talks about like the close interaction of the mom and the child often makes a big difference. And I know loads of anecdotal stories from Kerala where some parents have taken it on as a challenge, and then spend time with the children like day after day, and and then have made a significant difference even with non-verbal children.
Right. Absolutely. Definitely, parental care do impact epigenetic parameters. I think there is a recent movie also, I think, which came out in the I think it's in the OTT platform, where this I think it happened in Sweden also, where this Bengali family was actually labeled to be language disability person. And therefore, he was actually aggressively taken into autism centers and all that. I think there's a movie on recently that has been that is running on the OTT platform. I forgot its name there.
Yeah, that's that Rani Mukherjee thing, Norway. That Norway something.
Norway thing, right, Norway, yeah.
Mhm. That's based on a real life. It's not a movie only. It's
Right. Real life.
on a real life story actually,
Right. It's a real life.
which happened. Yeah. But Rani Mukherjee is playing the mom. Yeah.
That is where the migration actually really plays a role.
I haven't seen it. I've heard about it. So I mean, I have not seen it. I
Right.
think last message, we already over the time. One last message from all the panelists. The speaker gets to speak the first, huh?
Yeah, I thoroughly enjoyed with the discussion, because the more we discuss, actually we get to learn more about it, because we work in the silos in the laboratories and all, and we get to really learn a lot of things from you all whenever you actually tell your experiences and all. I also get to learn a lot of things from my clinician whenever I actually talk to him. So therefore, it's very important that we really have such interaction between the basic science and the clinical scientists very frequently. That's good.
Absolutely. I think this is required. Otherwise, there's going to be no progress both sides.
Absolutely.
Because sometimes you will be going and you may feel that something has a clinical relevance, which actually may not be.
Right,
And
right.
what we want you to see, you will not be seeing till
Right, right.
I think it has to be. And I think everybody on either side, some of them people feel everybody knows the best.
No,
But
no.
I think combined knowledge is the best.
Yeah,
I think that is Dr. Biju.
I think I completely agree with Dr. Banerjee. The one thing which is true is autism is very, very complex. And there is this interaction between genetics, epigenetics, and environment. And it's very imperative that we continue to, our basic scientists like continue to work on this, because we need to identify more environmental and epigenetic risk factors, because only then like we're going to try and tackle the situation. But also at the same time, it's equally important, I feel, like the late Isabel Rapin used to say in her talks, or don't consider autism as a disease. It is not a disease, and stop looking for a cure and stop striving for normality and think of adaptation, fixing, and considering the individual's needs, and tolerate socially acceptable differences. And, you know, like sometimes there are unique contributions from these children, and welcome them and try and like, don't try to like, you know, like make them normal. She
Yeah.
used to say so.
Yeah, nowadays there is nothing like normal and autism. It's neurodiverse, right?
It
The
is.
name is changing. It's neurodiverse, and I think Dr. Mainak, Vinod must be feeling the pinch, because we are not letting him go. We have started this new series, and every other talk he's either speaking or he's an expert, because genetics is everywhere. I mean, I think he's anyway a physician scientist. So we are pulling him all the time, and I wanted to remind him that we are going to start that platform, which we decided in the first talk he gave on personal genomes, where we stand as a personal genomes, and we had planned that we had start a platform between the clinicians and from the scientists, so as to understand and unravel some of the reports which we are not able to do that. So I think we'll begin that platform thing. Vinod, you can have the last say, and then I can talk to you how we can move about for that. And before we give it to Mahesh to conclude.
Yeah, thank you very much, Dr. So I think we are still scrambling at the surface of the problem, because we still do not understand the cause-effect relationship between the molecular mechanisms and what we see in the phenotype. I think, like every other disorder, which is a spectrum disorder, what molecular understanding can actually suggest is how we can stratify patients and indeed help some subsets of patients who could benefit from definitive therapies. Either it could be dietary, or it could be a pathway modulator, or a very specific therapy. I think the future looks good with better molecular tools available, and of course, better collaborations available. Thank you.
Thank you, Dr. Vinod. I just wanted to say that this is good that we are doing this in the month of April, which is a Autism Awareness Month. And the theme this year by the UN has been transforming the narrative, contributions at home, at work, in the arts, and in the policy making. That means we have to take them all along, and that is why the task force which we are having in DBT has all scientists and clinicians, and also a very leading parent advocate in that group. That's a beginning for us to go ahead. And when autism didn't stop Einstein, Newton, Mozart, or Temple Grandin, neither will it stop your child. That is what has to be told. And transformation towards a neuro-inclusive world for all. These are the few messages we from AOC and in the banner which we had circulated and created have done. So I think that is where we stand. And I think it's a joint effort between clinicians and scientists, and simultaneously empowering the parents and trying to understand the parents and the personal, the advocates, self-advocates in that. So we are going to be having a public health lecture in AIIMS next week on 25th, which is physical, face-to-face. So I think they probably will be recording and having it on YouTube. So we would like to get all these, advocates there, because we have to understand their point of view. And if you read Tito's, Mukhopadhyay's poems, that he is a wonder kid who's written in, about autism, the poems, you just see like, in that he said he moves his hand. We are just talking about stereotypies. He said he moved his hand, then only he felt that it existed. So we don't understand their point of view. We're just trying to say it's an abnormal movement. Stop it. We have to just understand from their side. I think it's time that we have to get them on. I really am grateful to all of you for there, and Krishanu to be there. I request Mahesh to give the concluding remarks.
I thank Dr. Moinul Banerjee for his wonderful thought-provoking talk. It has really raised a lot of interest in epigenetics and neurological disorders. I'd like to thank all the three experts today who have joined, Dr. Biju Hamid, Dr. Vinod Skaria, and Dr. Krishanu Rai. And I'd like to thank all the delegates who have attended today's meet. And we'll be continuing to have this What Do the Experts Say sessions. The details of the next meeting will be put up in both WhatsApp group and will be sent on email.
Yeah,
to you.
yeah.
And I expect.
Mahesh,
all of
one
you-
second,
Yes,
Mahesh. Dr. Moinak, I didn't ask for your permission to put this recording on the website. We are putting all the recordings on the website. Is it okay?
That's fine, because I have
thanks.
actually covered all the data which is not to be published, which are not shown
Okay.
here.
Okay, sorry, I didn't take your permission. Sorry. Mahesh, please continue. So we'll have it on the website. Yeah. Yeah. Mahesh.
So I thank all the participants for attending in big numbers. And we'll be sending the details of the next meeting on both WhatsApp and email. And I expect all of you to attend in big numbers. Thank you all.